everybody. I'm Managing Editor Michael Johnson. I'm joined today by Dr. Mark Reiner, a clinical professor of surgery at Mount Sinai School of Medicine, also a spokesperson for the Patient Protection Coalition. Thanks for joining me.
Thank you. Thanks for having me.
We brought you in today because we wanted to talk to you a little bit about the changes that have been taking place with in-network versus out-of-network and how that's been impacting patients. So can you just, before we get into the details, talk a little bit about what in-network is versus out-of-network?
Surely. In-network means that it's like an HMO, a health maintenance organization, where you're limited to the physician and the hospital that you can use. You're not allowed to go to a physician who's not in the plan, and you're not allowed to go to a hospital that's not in the plan. And if you do, there's no reimbursement to that physician or to that hospital, and it's a completely out-of-pocket expense. As opposed to an out-of-network policy, which says that if you go to a physician or a hospital that's not in our network, we will reimburse you for the cost up to a certain percent, and there's a methodology that they determine as to how much money they're going to reimburse. So the real difference is choice versus no choice.
So basically, I mean, to put this in practical terms, if you're diagnosed with cancer, you have to basically go to the doctor that's in network. If you wanted to go to a doctor out of network, you're looking at a significantly higher cost. So, you know, an out of network doctor might be far better expertise at certain cancer, but you might not have that option to go to them without having to pay a large.
That's correct. In an HMO, you can't go to an out-of-network facility unless there is an appeal process and there are extenuating circumstances. But most HMOs say, if we have a doctor that treats this problem or a hospital that treats this problem, that's where you're going to go. If you go anywhere else, we're not going to reimburse the physician or the doctor, and it's all going to be an out-of-pocket expense, which once again limits the choice as to where a patient can go and really doesn't take into factors such as the expertise of a hospital or specific individuals.
And I know Omni has taken several actions this year to address some of these issues, and I know they passed in the budget a bill that would limit out-of-network costs that happen during emergency room visits that people maybe didn't know about, also other surprise costs. Can you explain a little bit what happened there and how that has impacted the system?
Well, as physicians, we've been strong advocates of this. What would happen is a patient would come to an emergency room, and it would be an emergency. It was not an elective. Let's say they needed surgery. They'd be taken to the operating room. They'd be operated on. There are costs. This is the cost of the hospital, the operating room, the surgeon, the anesthesiologist, and an assistant, let's say. If they were in network, the patient was completely covered except for some co-insurance or whatever deductible they had to pay first. If some were in network and some were out of network, or if they were all out of network, the insurance company might only pay, since it's an emergency, their in-network rates. Therefore, the patient could get stuck with enormous bills. And we felt that that was unfair and inappropriate. So in the governor's budget, there is something now that addresses this. If a patient comes to an emergency room, no matter what insurance they have, and it is an emergency, and they are taken care of, and always the best example is to have surgery, because that's usually where most of the costs are, and they're operated on, the patient has no responsibility, if they have an insurance policy, to pay the hospital or physician other than their co-insurance and deductible. The fee will be determined between the insurance company and the doctor. The insurance company will pay that physician something within 30 days, and the hospital. If the physician or the hospital believes that that is not a fair and just reimbursement, and most of the time the insurance companies will base it on a Medicare-based rate, which is about 1/10 to 1/20 of a normal surgical rate, the physician has an appeals process. And in that appeals process, the state will look at, or the committee that will look at this, will look at usual, custom, and reasonable rates, which is the higher reimbursement rates, the expertise of the doctor, the location, and they'll come down with a number that the insurance company will have to pay.
Clearly this is good for the patients, but it seems to me there's an underlying problem here with the rates that they're setting with the insurance companies and the hospitals.
Well, this is a pure and simple insurance company manipulation that goes back to 2008, 2009, and 10. When then Governor Cuomo was Attorney General, he sued United Healthcare and Ingenix because they were manipulating reimbursements to patients. So at that time, there's something called usual, customary, and reasonable. And those are rates that are average rates based on location of what doctors charge. So UCR, or usual, custom, and reasonable, establishes a number. It could be 70, 80, or 90, or 100% of the average rate for your location. The insurance companies, their methodology was always based on payment based on UCR. However, they started their own company. That company manipulated the data so that there was about a 20% difference between true UCR and the Ingenix or United Healthcare UCR, which of course was lower, and the physicians and patients in hospitals were reimbursed at a lower rate. The settlement was $350 million. And Aetna just had the same issue in New Jersey, and they settled in 2012 for $120 million. So what the insurance companies did is said, well, the methodology that we used was not, hurt us, so we're going to establish another methodology. Part of the settlement was that something called Fair Health would be set up, which is an independent, nonprofit company that establishes UCR rates. And it's a formula, it's very fair, it's done, highs and lows are thrown out, and the numbers are put together, and the methodology is excellent. The insurance companies, though, didn't want to use that because now they would have to pay, based on UCR, a higher rate than they were paying. So they now decided, okay, we'll just base our reimbursement on Medicare rates. So they now pay either 100% Medicare, 110, 20, or 30% Medicare. Unfortunately, though that number looks like a real number, for the average patient, a surgical procedure of Medicare rate is fixed to the numbers from 1980. So that the numbers are really 1/10 to 1/20 of the true UCR rates. So the patient gets stuck with a very, very large bill.
What actions are the Patient Protection Coalition doing to try to combat that aspect of it? Is there anything moving in Albany, or you want to move through with the state legislature to try to combat that?
We've been trying for a long time to say that the insurance companies should offer a usual, customary, and reasonable rate of reimbursement to patients. Their argument is always, well, it's too expensive. And my argument back to them is, well, just make it available. Okay? If it's too expensive, nobody will buy it. But a perfect example is, in my practice, I just got insurance, and I, as a small group, and that's defined as 2 to 50 full-time employees, cannot get an insurance policy based on UCR. So I had to take a Medicare-based 130% policy. That cost me more money than my UCR-based policy. And it's the reimbursements are dramatically less to my doctors, okay, and to doctors in general, and the hospitals. So they can say all they want. The reality is that no one's looked at the numbers, and even if it is a little bit more, why not give patients the option of taking what they want, and if it's too expensive, they just won't purchase it.
And another thing that we talked about before the interview started, just in general, the individuals and people, groups that are less than 50 are looking at the possibility of not being able to have access to out-of-network coverage once the health exchange is fully up and running.
Well, the health exchanges, we got originally in the health exchanges, they were mandated to offer an out-of-network policy as one of their policies. Then unfortunately, 2 or 3 months ago, they reversed themselves, the state, and they said that they don't have to offer an out-of-network policy. What that does, though, is there are 62 counties, I believe, in the state of New York. 54 counties do not offer out-of-network policies to individuals. So that if someone wants to buy a policy, okay, or they're in an ACO, they will not be able to go to the doctor or the hospital of their choice. And that really is a travesty. Patients should have the right to choose, okay, and insurance companies should reimburse at a legitimate rate of payment so that the patient's out-of-pocket expense is not high.
And looking ahead, because I mean, obviously the legislative session's done for this year. They're probably not going to come back and address anything until next year. What's the one thing that you would like to see move through Albany next year to try to deal with these rising costs?
We've taken care of the surprise billing, I think, which is great, and the way it was done is excellent. The next thing we need to do is to ensure that every citizen in the state of New York, whether they're in an ACO, whether they're a blue-collar worker or a white-collar worker, they need to be able to go to the doctor and the hospital of their choice. Insurance companies should be mandated to, and they can do it, the DFS can do it, they should be mandated to offer out-of-network policies. And when they offer these out-of-network policies, at least one policy should be based on usual, customary, and reasonable, and that the insurance company should be completely transparent. It should say, this policy pays this amount for this operation. Our UCR policy is this amount. The average is this amount. So that the patient and the individuals can make a legitimate decision as to what is in their best interest.
Dr. Mark Reiner, thank you very much for joining us.